end exactly. I'm watching the clock for the last minute. Good morning. Thank you for coming. We are very pleased today to have a number of people from OSU. One of the doctors has some medical issues, so is not going to be here. So Dr. Lesser, who will introduce himself, will be answering all the questions. Most of you know I'm Bonnie Pratt. I'm chair of the Low Vision Focus Group, which formed about a year and a half ago. And this is Sandy Cornett. She's chair of the Healthcare Committee who fostered the focus group. In February of 24, as most of you know, the Healthcare Committee formed a focus group to investigate ways to improve the accommodations of our low vision population at the village. Over the past year and a half, many questions have been asked in this Q&A in this year. Prior to this meeting, we have asked for questions to be solicited from our low vision population. And those are the questions that have been submitted to Dr. Lesser. And so I will read the questions, he will answer them, and then we will open it up to the audience. Okay, thank you.
Thank you.
Do you want to go first and introduce yourself?
You do your thing.
All right, I'm Laura Sladoji, and
Hold the microphone up to your mouth.
okay, I'm Laura Sladoji, and this is my team from OSU. Beside me is Lori Schumacher, Mackenzie DeMarco, and Shane Peterson. It sounds very loud.
Oh, yeah.
Also, people with low hearing.
Okay, let's try again. My name is Laura Sladoji. I work in the Department of Ophthalmology at Ohio State with Lori Schumacher, Mackenzie DeMarco, and Shane Peterson. And a few of us will be at lunch afterwards, but I did want to tell you we brought some materials that you can read at your leisure. I have a few things in my hand, along with some lens cloths and some stress eyeballs. All right, with no further ado, I'm going to introduce Dr. Alan Letson.
Thanks, Laura. Can you all hear me if I speak loud enough with the microphone on my chest here? Can you hear me okay? Okay, good. I gave a presentation somewhat similar to this maybe 15 or so years ago here. And it was a PowerPoint presentation, and I think some of the audience got it and some didn't. And I looked around, and a fair number of the people in the audience were my patients, and I knew that they had macular degeneration and things like that. So this time, when I was asked to do this, I thought it might be easier and better just simply to answer questions and give people the opportunity to ask questions, and in a more informal context rather than showing fancy pictures and that sort of thing. So with that, I guess we can start. Is that all right? Okay. By the way, I'm a retina physician, so I can answer the retina questions pretty well. I don't know about the glaucoma part. I'll do my best.
I will read the questions, and Dr. Lesser will take it from there. The first question that was submitted is, what is the hereditary component of macular AMD?
There's a very strong hereditary component to it. There are at least 50 genes that have been recognized that have a significant role in increasing the risk for developing macular degeneration. There's no one gene that's responsible for it. And it's not only the combination of genes, we can look at different combinations of genes and see different levels of risk. One of the questions that always comes up with this is, should you do genetic testing? Right now, I don't think there's a role for genetic testing just in terms of everyday patient care. We're going to treat everybody the same with what the tools are that we have. As the tools become more sophisticated and we get farther into genetic types of treatments, then we may start doing genetic testing to see if there's a particular drug or treatment that is going to be more applicable to that set of genes. We're doing that now with some of the hereditary retinal diseases. retinitis pigmentosa, things like that, where there are certain genetic types that we actually have gene therapies for. Right now, we do not have any gene therapies for macular degeneration. However, they're in the works, and there are some currently that are in the stage phase 1 and early phase 2 clinical trials. So it will be probably at least 3 or 4 years before we have any data from those kinds of trials. So I don't envision gene therapies yet for macular degeneration, although it's on the horizon. We have in our department a geneticist, a retina doc who's a geneticist as well, who is working on genetic retinal diseases. And he's doing gene therapy for retinitis pigmentosa down at Children's Hospital for kids. And he's very excited about what's coming down the line along the lines of macular degeneration. So we do have people even in our own department who are working on that. So that may be something in the next few years that will come around.
The next question are, what are some of the newest and most promising treatments for wet and macular dry
Degeneration. I'll start with wet, since that's the more developed of the two. For those of you who have wet macular degeneration, you know the treatment is injections. And the injections are a class of drugs that we refer to as anti-vascular endothelial growth factor inhibitors. We just say anti-VEGF, that the acronym is VEGF. And those drugs were first developed back around 2005, and through the years there have been, by different drug companies, different advances in terms of either potency or durability for the anti-VEGF drugs. And we've reached a point now where we have some fairly decent drugs, I'll talk about as we go through this question. One of the barriers to using these drugs, though, is cost. And some of you may be familiar with how much some of these drugs cost. The drugs that started with Avastin, which is interesting, that goes way, way back. Avastin was the first anti-VEGF drug, and some of you may still be on it at this point. Avastin was originally developed to inhibit the growth of blood vessels in tumors, so it was used in cancer treatment. And it was then people decided, well, if it's inhibiting blood vessel growth, that's what wet macular degeneration is abnormal blood vessel growth behind the retina, and it leaks fluid and bleeds and causes scar tissue. If we can treat that with Avastin, maybe we can start treating wet macular degeneration. So this was back about 2005, and it worked. And so as it turned out, Avastin was, I won't say bootlegged, but it was never tested for the FDA for use inside the eye. So the original use of Avastin was what's called off-label. And once a drug is being used off-label, once you gather enough data on it, then you can go ahead and use it. It still has never been FDA approved for use inside the eye, but it's considered a standard of care. And so people can use it. Now the trick is the company that makes it, Genentech, only packages it in packages that are used for the cancer patients. So they're vials of 5 cc's, a pretty big vial. What we inject inside the eye for any injection is 0.2 of a cc. So that's a really small amount. So when we get the other drugs, we always get them in preloaded syringes that are just a barely amount of drug that will fill the needle, and then we can inject inside the eye and deliver the treatment. So Avastin costs about $500 for one of those big vials. And with Avastin, we can get enough samples out, enough treatment supplies out of that, enough syringes out of that to lower the cost to about $50 to $70 a dose, which is pretty reasonable. All these other drugs, from that point on, their cost is anywhere from about $1,600 to $3,000 per dose. So you can imagine the burden financially that can be. Now, Medicare covers, it's part of Part B, so it covers 80% of that. And then if you have a supplemental, that will cover the rest. or you may have to pay for the balance, that 20% out of the pocket. There are a number of different ways to get that covered. But anyway, what's happened is third-party payers, not Medicare, they still pretty much cover everything. But if you have a third-party payer that's not Medicare, they may say, gee, we're going to require that you start with Avastin. And if that works, fine. And that's what you will be on, is Avastin. If it doesn't work, then the doctor can make the case to move up to one of the more expensive drugs. So when all these were given on monthly to 4 to 6 week intervals, which was pretty standard for a long time, up until about a couple years ago, that seemed to be okay. But now we have 2 drugs. I don't have any financial considerations in any of these drugs. I'm just going to say them because we use them a lot. One is Eylea. Seemed to be a very effective drug, and the first formulation of Eylea was a 2 milligram dose and 0.2 of a cc. And we could, after a series of monthly treatments to get everything dried up, we could maintain that with injections anywhere from 4 to 6 to 8, sometimes 12 weeks. That would be pretty exceptional to go that long. The new version of Eylea, you can go up to 4 months in between injections. So the difference between getting an injection every month versus 3 times a year is huge for everybody. And so that is one of our favorite drugs right now, is what's called Eylea HD. If the insurance covers it, we can use it. If not, we may be stuck with something else. The other drug that has become popular in our department is, you've probably seen TV ads for it, is Vabysmo. And that actually has 2 forms of VEGF inhibition, actually a VEGF inhibition and an angiopoietin-2 inhibitor, which also stimulates blood vessel growth. And with that one, that can also be extended up to 4 months in terms of the intervals between injections. So those 2 are probably the heavy users, at least amongst the retina faculty at Ohio State. There might be differences in the community about that. We find that not everybody responds to the same drug. And so sometimes we'll start with Avastin. If that doesn't work, we'll try Lucentis, or we'll try any of the other drugs that are out there. And some of the drugs have shown to be problematic in that a fair number of patients will have allergic reactions to them and have inflammation inside the eye. So some of the drugs that do that have sort of fallen out of favor. And so we still pretty much have as our backups, as our main line, Avastin, Lucentis, Eylea, Eylea HD, and now Vabysmo. And so the Eylea, Eylea HD, and Vabysmo seem to be our next 2 drugs, at least in our department, after starting somebody on Avastin, if we have to start there. The next I was going to...
Dry macular? Would you address dry macular?
I was just going to do that. Yes, thank you. Yes, sir.
What's the difference between Eylea and Eylea HD?
It's the concentration of the drug in the...
Repeat the question.
The question is the difference between Eylea and Eylea HD. And so Eylea has 2 milligrams per unit of dose. The HD has 8 milligrams per unit of dose. So it's a stronger dose. And people were worried about stronger doses because some of these drugs, well, not some, all of these drugs do get into your systemic circulation. And with anti-VEGF drugs, there's a concern with too high of a dose causing things like strokes and heart attacks. So they had to do a clinical trial comparing the 2 milligram to the 8 milligram dose. As it turned out, there was no difference between the 2 in terms of that kind of a risk. So now we feel very comfortable using the stronger dose. In terms of the risk of heart attack or stroke after any of these drugs, it's about 4 out of 1,000. And that we're already dealing with a population in our age group that may have heart attacks and strokes anyway. So it's hard to know whether they're related to the injection or not. So,
Thank you.
yeah. So as far as dry macular degeneration, as many of you know, for a long time we had no treatment at all, no medical treatment. And I was a co-investigator for the ARIDS trial and a principal investigator for the ARIDS 2 trial, so I was involved in these quite a bit. And what we learned from the ARIDS, the initial study, was that these vitamins supplements could reduce the risk of advancing to, quote, severe vision loss. And that included the development of wet macular degeneration as well as progression of dry macular degeneration. We also learned that the beta-carotene that was in that original dose also caused an increased risk of lung cancer. So the beta-carotene has been removed, at least from the AREDS-2 preparation. The AREDS-2 trial added lutein and zeaxanthine, and with that we found that persons with intermediate stages of dry macular degeneration. Now maybe you've heard your doctors talk about drusen in your retina, the little dots that we see on the photographs, little deposits under the retina. For those people with intermediate and large drusen, the AREDS-2 supplements reduce the risk of progression of dry macular degeneration. It didn't stop it, but it slowed the rate of progression down. Most recently, there was a study done looking at using AREDS at earlier stages of dry macular degeneration. That is when you first saw a little bit of pigment mottling, maybe some drusen in the eye, still had good vision, maybe had a tiny spot of geographic atrophy or none at all, and it showed a 55% reduction in the rate of progression of earlier stages of dry macular degeneration. So one of the questions that was sort of a sub-question was, what can I do to minimize the problem of dry macular degeneration? And that's take your AREDS-2 vitamins. That's number one. In terms of diet, eat leafy green vegetables, colored fruits, nuts, fish, have a low glycemic index diet, not a lot of processed, highly processed foods. More natural foods are better. They carry more antioxidants in them. Get exercise. Make sure your blood pressure is under control. Make sure if you have diabetes that's under control. Don't smoke. Smoking is the worst thing you can possibly do for your retina. So if you are a smoker, hopefully you're not, but if you are, please stop. That would be my advice. So those are the sort of things that you can do from a medical standpoint. We do advise people to monitor at home an Amsler grid. I don't know how many people use an Amsler grid. It's the little sheet of paper with an X and a bunch of grids, and you look at the center of that to see if there's, and try to be aware of any distortion or smudges or missing lines on the chart. We encourage people to do that. I just lost my train of thought. I was going to follow up on what you can do at home. Oh, monitoring. Some of you with glaucoma may be using an eye care home monitoring device for measuring your intraocular pressure. Soon there will be a device that you can use yourself that will measure your retinal sensitivity in terms of geographic atrophy and changes in the retina related to macular degeneration. And that's something that you can do to monitor at home. Monitoring was the question I wanted to address. We still suggest that we recommend, not just suggest, recommend that you have regular follow-ups with your retina doctor or your ophthalmologist, because as we're learning about the new drugs I'm going to talk about in just a second, monitoring becomes very critical in terms of knowing, A, is it working? B, when do we start using it? And so currently we have 2 drugs that are available to treat dry macular degeneration. They're also injections, just like for wet macular degeneration, except these aren't aimed at particular genes, but they're aimed at the products that the genes produce that cause inflammation and damage to the tissues. So they're both complement inhibitors. If we look at the genes for macular degeneration, there are a ton of them that are in what we call complement factor area. And so these are drugs that inhibit the byproducts of those complement genes. And with those, again, these injections will not cure dry macular degeneration. They won't restore vision that's been lost, but they do reduce the rate of progression. And so that's where monitoring comes in. These drugs are also very expensive. They're about $3,000 a dose, and you get them every month. And so far, we don't have any long-lasting versions of those, so it's a monthly injection. And so getting to and from the doctor is a burden, all those sorts of things, the cost factors. So what we're trying to learn right now, this is where we are with these injections, is who should be started on these injections and when. And so a paper was just produced about a month or two ago that looked at progression of geographic atrophy related to visual acuity and overall visual function. And this study indicated that if somebody had an area of dry macular degeneration, of what we call geographic atrophy, where the tissues that you need to see with are dying away, if it's within a millimeter, a 100 microns of the center of the fovea, and you still have good useful vision, that person should be on these injections. The question that now presents itself is we know, okay, that's sort of like the emergency level where we should be doing this. Is there a level where we should be doing it sooner? And we don't know the answer to that question yet. So we're still studying the long-term life cycle, if you will, of dry macular degeneration and getting a rate on progression. As I mentioned earlier, with the AREDS vitamins, if you start taking them at an earlier stage, the rate of progression is reduced by 55%. That's a huge number. And so that may itself just simply limit how many people are going to hopefully need injections. But I would say this is still a work in progress in terms of when should you get those injections. All the more reason to be monitored. And monitoring now is a lot more sophisticated than it used to be just using the Emsler grid. When you go to the retina doc, you're probably going to get an image that looks at what we call autofluorescence. Autofluorescence is a tool that shows us about the health of the pigment layer of the retina. That's the part that macular degeneration affects. And we can start to see that if that pigment layer is becoming damaged and the areas that have already died are getting bigger, that tells us this is progressing, and it gives us an idea about rate. So it might be a situation where you're going to go in maybe every 3 to 6 months and have an autofluorescence image, or in the future a microperimetry image that doesn't measure cell death, it measures function, which is an earlier level of detecting injury. And so we have tools that are being developed that are going to be very useful for monitoring, and that may help us. It will dictate perhaps when we start doing these injections. So right now there's a lot of unknown about using the injections. Yes?
Since you spoke about AREDS too, is there any benefit to people that just have a high family, high heredity of getting macular degeneration for them, even though they haven't been diagnosed with MD, for them to start taking AREDS too?
Yeah, that's a really good question. I've always wondered that myself. And I think the recommendation now would be, for those people who are even thinking about macular degeneration, by the age of 60, you should start having regular, that is, annual eye exams. It's unusual for somebody at the age of 60 who shows no signs of macular degeneration to get it. So that sort of is a border that if you can cross that border and not have any macular degeneration signs, it's not an absolute guarantee, but you're probably not going to get it. By the age of 60, people who are going to have macular degeneration will already start to show some drusen or pigment modeling. It may be very subtle, but those will be the earliest signs. And this is where we still don't know. It could be decades before vision issues really arise. As I just indicated, though, the AREDS vitamins have been shown at early stages, where there's just maybe 1 or 2 drusen and a little bit of pigment change, that if that were picked up at age 60, you might be able to out-survive the loss of vision. And so the answer to the question, should you start taking it, I don't know if you should, just if you don't know if you have it or not. I would say get an eye exam. And by the age of 60, if you do show a hint, it's probably worth taking. That would be my impression.
Are they good vitamins for your eyes regardless?
Well, they're good. They're good vitamins for the rest of you regardless. Yeah. There's no contraindication. I mentioned the beta carotene, which isn't in the AREDS 2 formulas. Now, this is where it gets tricky. One of the original questions that was submitted to me was about preservision. And I don't do shopping for vitamins, but I happened to be in Costco not too long ago with my wife, and so I thought, well, I'm going to go look at the shelf with all the vitamins. It's like, oh my gosh, I can't believe how many different versions of Preservision there are. And I would say, I can't tell you about all of them. It seems to me they're all trying to address different things. Some of them have the fatty acids that you might need to lower cholesterol and protect your heart. And we don't know that those do anything for your eyes. And so there are different formulations and versions. But whichever one you get, as long as it says AREDS 2 on it, that would be okay. The AREDS 2 nameplate is the important part of it. Yeah.
Okay. Are there any new developments that replace cataract surgery?
Not that I'm aware of. There are things that you can do for presbyopia that sometimes people, they have a hard time reading. There are eye drops you can use that make your pupil small, and that changes your depth of field. And those might help a little bit during the early stages of cataract when people have a shift in their focusing power inside their eye. I know when I got cataracts, I never wore glasses, and all of a sudden I was becoming nearsighted. Cataracts will do that. They increase the density of your lens, which increases the power of your focusing, and you become nearsighted. And so if I had maybe constricted my pupil, I might have seen better, and I could have delayed the surgery for cataracts. But I'm not aware of any drugs yet that will prevent the formation of cataract. The only treatment is to remove the cataract, and that's surgical. We do know about causes of cataract, and again, there's family history related to that. A lot of environmental factors play a role in cataracts. So certain kinds of light exposure might play a role. We know that people that work in steel mills and glass factories where there's a lot of heat and infrared get infrared types of cataracts. We know that people that work out on the bays catching fish and harvesting oysters and whatever get a lot of UV exposure, ultraviolet light exposure, and that can cause cataracts. So protecting your eyes against those kinds of light sources is valuable. There's some concern about the computer screens and iPads and cell phones and all the screens that we look at. They all emit very high energy, short wavelength light, which can be damaging to your retina theoretically. We don't know how significant that damage is, but that may also play a role in cataract formation. But the most significant, I think that are related to cataract formation is your metabolism. And so if you are diabetic, that cataracts and diabetes are almost a given. If you have issues with blood sugar control, if you have other metabolic issues, a lot of things that relate to our metabolism affect the nutrition to our lens, and that can cause, or at least promote, the formation of cataract. One thing that happens to all of us as we age is the gel material that fills inside our eye collapses, and when that happens, then the eye is just a big space that has to be filled with the aqueous fluid that's made. That aqueous fluid turns over fairly rapidly before that vitreous gel turns over. It's sort of like the turnover of water in Lake Erie. It takes a few years for that to turn over. But if you look at Lake Superior, which is massive, it takes a century for the water there to turn over. So after you have a gel separation, that aqueous still flows at the same rate, but now it has to fill a huge cavity. So what happens, the nutrition to your lens becomes compromised. And that's the aqueous fluid nourishes your lens. And so with that compromise, that probably promotes cataract formation as well. So there are, again, dietary things, light source things, food choice things, behaviors that you might choose that can maybe slow down or prevent formation of cataract. But once you have it, there's no drug that I'm aware of anyway that will stop it or cure it. And the only treatment is surgery. So, yeah.
Are there any new developments in the treatment of glaucoma?
That was going to be a question for Dr. Weber, and he's not here. Glaucoma treatments, probably there are always new drugs being made. I could show you a list of drugs that prevent the formation of aqueous fluid and a list of drugs that increase the outflow of aqueous fluid from the eye. Those are things that we use to try and control pressure. And those lists of drugs are long. I mean, there's many, many, many drugs, and they're all variations of the same thing. So from the drug standpoint, I'm not aware of any new drugs that are radically different unless it relates to some peculiar circumstance of any given individual. We all know that some drugs work in some people and other drugs work in other people. And that's the way with these formulations. So sometimes the drug aspect of it is just trial and error. There are always new drugs coming on, but they all sort of do the same thing, maybe just better for different people. As far as what happens after drugs fail to work, the next thing is surgery. Now, the surgery could be laser surgery. There was a paper published this past summer that showed a laser procedure, this may be a new concept, called selective laser trabeculoplasty, was as effective as the initial frontline treatment using medications in terms of lowering pressure. To me, that would be pretty exciting. If I could sit in front of a laser for 15 minutes and have a treatment maybe once or maybe twice and not have to put all the eye drops in my eye, forever, that would be huge, I think, from a quality of life standpoint. Yes, sir, were you going to ask? Oh, I thought you were.
How about peripheral iridotomy?
Well, that's used for what's called narrow angle glaucoma. And that's how you're made and put together. And if you have narrow angles, the risk of that is what's called acute angle closure glaucoma. The iridotomies are curative of that. So most of the medications we're talking about are really for chronic open angle glaucoma. So two different forms of glaucoma, but thank goodness the narrow angle is curable. Open angle glaucoma is not curable, but it's treatable, and you can maintain and control it, hopefully. If the medicines don't work, then the laser is the next step, more advanced forms of laser treatment. The next step is a procedure called trabeculectomy, where a hole is made into the eye that lets fluid leak out of the eye under a flap that's made and absorbed into the tissues in the orbit. One of the issues with trabeculectomies is they can scar over and they have to be repeated or new trabeculectomies made, so those are surgical procedures. Probably the newest thing are little microscopic stents that go into the portion of the eye where fluid flows out of the eye naturally. And the abbreviation, the acronym for that is MIGS, M-I-G-S, and minimally invasive glaucoma surgery. And these little stents are about the size of the D on a penny, the mint stamp on a penny. Those stents are that size. They're almost they're not quite microscopic, but almost. And these can be surgically plugged into the outflow channels on the inside of the eye. And they make fairly large openings without you having to cut incisions or make flaps in the eye. So from a safety standpoint, they're potentially much safer. They're fairly new. We have one person in our department who has started to he actually came to our department as a person that specialized in that particular procedure. So that's probably the newest thing, is the surgical aspect of putting these stents into the eye.
Okay, thank you. Please comment on a procedure using amniotic fluid from the placenta to treat dry macular degeneration.
So in terms of the literature that I would pay attention to as a physician and a clinician is, I'll be honest with you, I'm not aware of any amniotic fluid studies being done in humans for treating macular degeneration. Now, having said that, I'm sure somewhere in a lab, somebody might be doing something with that with animals. I wouldn't be surprised. One of the things that relates amniotic fluid to potential regeneration of cells is that there are a lot of what we call stem cells in amniotic fluid. And so, as many of you probably know by now, when we're born, we have a lifetime supply of retinal nerve cells, and we don't get any more. They don't multiply and divide like cells in our skin or those sorts of things. You get one set and that's it. And if they die off, we can't replace them and we can't transplant them. I always used to get the question, why can't you transplant a new retina into my eye? As it turns out, the axons of the ganglion cells in the retina they go all the way back into your brain. So it's not just taking out an eyeball and putting a new eyeball in or putting a new retina in. You'd have to be able to somehow transplant the entire visual nerve pathway into your brain to make that work. And we don't know how to do that. And we don't know how to make new cells grow. But that's where the stem cells come in. And so we're a long, long, long way from being to the point where we'll be able to grow new nerve tissue inside the eye. But I'm sure that's what, somewhere in a lab, people are doing something with amniotic fluid for that.
Interesting.
Yeah.
What causes a corneal hole? And what role does scar tissue play in vision? And is it wise to remove it?
So, you showed me that question earlier, and I don't know if the person asking that question meant a macular hole. I don't know anything about corneal holes other than if they're perforations made by infections and inflammations or trauma that would actually make a hole in the cornea. You can replace corneas, and you can make little patch grafts to plug holes in the cornea. But those are all surgical procedures to do that. The fact that the question included scar tissue and maybe alluded to retina makes me think the question might have been about a macular hole. Macular holes aren't real common. It's estimated that maybe about 8 out of every 100,000 people will develop a macular hole. The macula is the center part of the retina, as you know, that you need to see with in terms of detailed vision. And when people go through vitreous gel separations, a small percentage of those people will have a persistent adhesion to the surface of the retina right where the macula is. And when that gel collapses and pulls away from the retina, it can make a tiny hole. And a hole sounds huge. A macular hole is measured in microns. We're talking about something that might be 100 microns in size. If they're at early stages of formation, they can sometimes heal themselves. If they develop the stage of a full macular hole, if they're repaired while they're small rather than as they get bigger, we get better visual results. But again, it's a surgery that's required to repair a macular hole. So I don't know if that answers the question. If whoever asked that is here, they can elaborate more, I guess.
The next question is, what resources are available to help patients adapt emotionally and practically with vision loss? We have addressed that many times in our meetings with the low vision, what resources are out there. Do you have anything that you particularly favor or know about?
I think there's nothing particularly new along that particular question line. Everybody's different, and everybody has different needs, and everybody feels about their vision and how their life is going differently. So I think support groups in general are helpful, just from the psychological standpoint. Somebody may have discovered a little trick to living their lives that may help somebody else that can be passed on in that scenario. If they're led by low vision specialists, they can address more specific needs, and all the little gadgets and things that we use, whether they're magnifiers or closed circuit TV, big screen things, or whatever. There's all kinds of technology to help people see better. But in terms of the everyday low vision world, I don't think there's anything radically new, unless I get into newer technology that is pretty exciting. And this, I think, is another question, but I'll go ahead and address it if that's okay with you. And that's things like AI and smart glasses. And there's also the little chips that can be implanted into retinas, and there's telescopic lenses that have been used. I'll talk about the telescopic lenses first. We tried them at Ohio State, and they just wreaked havoc inside the eye. And they're big, heavy, relatively big, heavy objects being supported by flimsy tissues. And so they can dislocate and bounce around. And one of the difficulties was it reduced the field of vision in those eyes to whatever the magnification allowed, which is, if you like look through binoculars, you don't have the nice wide peripheral view. You have about a 7-degree field in most binoculars. And so that's pretty hard to use for navigation. It might be fine for looking at this piece of paper with the print on it, but you're still using your peripheral vision for that task. At the same time, you've eliminated the peripheral vision from that eye for your everyday walking around tasks. So I'm not surprised that the implanted telescopes have not taken off. There are a few people that like them, but in general, those haven't really panned out. As far as replacing the retina with an electronic sensor that stimulates the retinal ganglion cells to take that electrical impulse to the brain, those have been used in people with hereditary retinal diseases like retinitis pigmentosa, where the photoreceptors are dead, just like it is in macular degeneration. And people can get some crude but useful vision out of that, but it's not to the point where they're going to sit down and read a novel. It's more of a navigational tool. And again, because it's a foreign element, it's made of metal and plastic and all these other things that are foreign to the eye, eventually scar tissue forms over them, or they can dislocate, or they can cause detached retinas or bleeding or scarring. So it's not the perfect solution to the problem. But I think until we know how to grow nerve cells and retina cells back, what I'm really excited about personally are smart glasses. And I don't know if everybody's heard about smart glasses or not. Y'all might remember the black Ray-Ban sunglasses with the big, heavy black frames. I don't know, they were popular back in the 50s and 60s. But Meta, the people that are Facebook, they also do a lot with AI and virtual reality. And the smart glasses have a camera in them that through Bluetooth links to an app in your phone. And there's a service that you can dial up called Be My Eyes. And so you wear the glasses, you call up, and a person at the other end is seeing what your glasses are seeing. And so if you need to read a sheet of instructions, they can tell you how to get it lined up, and they'll read it to you. If you're in a grocery store and you have to check the price or a label on something, you can call them up and they'll see what you're looking at, and they can give you that information. Or if you're walking in a strange environment, they can navigate for you. They can see what's coming down the street. You can look both ways and see if there's a car coming. So from a navigational standpoint and an information transfer standpoint, I think smart glasses are going to be huge. I hope it will get to the point where the AI part of this can eliminate the person that you have to call. In other words, you just wear the glasses and you can select a function that's going to either talk to you or give you instructions or whatever and interpret your environment for you as you're walking around. And I think that would be huge. Yes?
Correct me if I'm wrong, but I was under the impression that Be My Eyes will also work with just a smartphone.
Yeah, that's it. That's correct. It's an app on your phone, and the app connects to the glasses through Bluetooth.
No, but I mean without the glasses. I mean you can call.
Oh yes, yeah. You can that's correct. Yeah, you can use the camera on your cell phone. Thank you. Yes, I was so excited about not having. The problem with this is you lose a hand, and if it's the glasses, your hand's free, which allows you to do lots of things. So that's why I'm very excited about the glasses part. But you're absolutely correct. The app exists that you don't have to have the smart glasses. You just have to have an iPhone or an Android phone, whatever. It'll work with any phone, any cell phone, and you just have to aim the camera at what you want them to see. But that's true. They will do that just with the app on the phone. Yes. Yes.
Well, they told them I have wavy cornea.
Mm-hmm.
And they told me I take Neuro 128.
I'm going to give you the
Okay. Yes. The question was about a wavy cornea and the use of Miro. And so Miro is a lubricant, and it helps stabilize the tear film on the surface of the eye. A wavy cornea could be any number of things. Normally, Miro is used in dry eye scenarios and people that have erosions on their cornea or ulcerations and they need lubrication and hydration. A wavy cornea could be just an astigmatism, which can be fixed with glasses or contact lenses. A wavy cornea could be something like keratoconus, which can be a real difficult problem. Keratoconus is where the cornea stretches, and as it stretches, it gets thinner, and as it gets thinner, it gets very irregular surfaces that makes focusing very difficult. And so nowadays, you can do two things. You can have a rigid contact lens that's a special lens made for your particular eye, and that falls under the category of what's called specialty contact lenses. And optometrists, we have a couple optometrists in our department who are specialists in that. Sometimes if the fit isn't too difficult, just a regular hard contact lens might work in a less severe case. The other thing that you can do is transplant the cornea. Just take the bad one out and put a new one in. I don't know if that answers your question or not, but.
The doctor said something about shaving the cornea. Shaving.
She said to ask the doctor, told her about shaving the cornea.
Did they mention LASIK, using the laser?
I don't know, I go back to him soon.
Okay, because generally the shaving that is done with an excimer laser, and that's done to change the contours of the inside of the cornea, to change its refractive curvature. Sometimes you can correct astigmatisms with that. Sometimes there are people that have diseases with what's called the basement membrane of the cells that cover the cornea, and you can, and those can cause chronic irritation and discomfort, and tearing and burning and scratchiness, and it can be pretty miserable with the basement membrane. And with the laser, you can ablate that basement membrane and let the cells grow back and eventually form a new basement membrane. So maybe that's what you're being treated for. I don't know. I need more information to answer your question accurately. Yeah.
The last question on our list, and then we'll open it up to the audience. What are the pros and cons of tinted glasses in the low vision population?
I guess it really depends on the symptoms that you're having. There's always pros and cons to whatever choice you make. If you have issues with glare, bright lights, excuse me, tinted glasses can cut down on the glare and they can reduce the discomfort related to glare, but it's also going to decrease your what we call contrast sensitivity. And if you have a retina that's already not working very well, if you start reducing illumination and contrast, it's going to be a lot more difficult for you to see. And so in terms of tinted lenses, there are tints that will optimally stimulate the cones in your eyes and suppress the function of your rods, and the vice versa. There are tints that will suppress the cones, and that's okay, because if your cones, which are in your macula, are already not working because of macular degeneration, you can let the rods take over. The rods are the cells in your peripheral retina, and so those wavelengths of light may be helpful in terms of increasing the rod function in daytime hours. Now, those kinds of lenses, because the rods turn off under normal light circumstances, those are going to be relatively dark lenses, but at the same time, they'll let the rods work at their maximal efficiency. So again, whether that's going to help one person, it may not help another. It's highly individualized in terms of whether those things are going to be useful or not. There's no harm in trying them. There's no danger or harmful effect, but you might find that one type of a spectrum of light that's being transmitted is better than another. You might find that a 15% transmission is better than something that blocks out 30% or 60% of the light. On the other hand, you might prefer the 60% reduction. So again, it's highly variable and personal in terms of which kind of tint and how tinted it is going to work for you. So a lot of trial and error, I think, in that.
Thank you.
Yes.
Is there a kind of service life expectancy on cataract lens and surgery?
The question is there a life expectancy on the duration or time limit on cataract surgery?
So if you are buried, 1,000 years from now, somebody might dig up that grave and find a perfectly operable, perfectly functional lens implant sitting there. They're plastic, they're a polymer, and they're not going to degrade or break down. The lifespan of the actual lens implant is forever. Well, not really forever, but nothing's forever, but for a really, really long time. And so maybe another question is, though, will you need to do something along the way because you have an implant? So that implant, when it's put into your eye, sits in an envelope that was what we call the lens capsule, and the implant is put into that. And sometimes, actually in about 50% of people that have cataract surgery, that capsule can get cloudy. And so when that gets cloudy, your vision, you might get glare all over again and halos and all those cataract symptoms, decreased vision. But that problem is remedied in about 2 or 3 minutes when you sit down in front of a YAG laser and they vaporize that capsule and make an opening in it. So that's an easy problem to solve. And those are otherwise, the implants are pretty durable.
Okay, we have about 10 minutes, and we'll open it up to the audience, and we will repeat the questions.
Oh, are you asking?
No, do you need this? Do you talk loud enough? We'll repeat it.
Getting back to the glasses,
Hold the microphone up to your mouth.
if you have macular degeneration, other than getting the tint on the glasses, does it help to like get anti-reflective lenses or even the glasses? Does it help to have lenses, have frames that are invisible?
So the question
It's
is,
like, how can we get more light into our eyes? Because that seems to be a big problem.
So the question is, how can you get more light into your eyes in relationship to having reflective surfaces on glasses or the different tints? Is that fair? So
Or just different frames.
different frames. I don't know that the frames are going to make a lot of difference unless you have small glasses. So you notice I have a frame just minimally on the top of my lenses. And so I have just bare glass on the edges. And so I don't have a piece of plastic or anything blocking my peripheral vision. So I know everybody who's using peripheral vision, that could be a big deal. And so I think working with a guild optician who knows about eye diseases and knows about what to do in terms of positioning of the frames, even if you don't have frames and just have the glasses themselves with a temple to keep it on your face, even the size of the lens may make a difference in terms of how you can use your peripheral vision. It also depends on your prescription. With strong prescriptions, you start getting weird prismatic effects. Things jump in and out of your vision because of the prism effect of the edge of the lens. So if that's the case, you may need either bigger or smaller lenses depending on how much of a peripheral field you need to use versus your central field. Smaller lenses have less prismatic effect compared to big lenses. Big lenses, on the other hand, let you see more of your peripheral field. So there's trade-offs from that standpoint. In terms of reflective lenses, I don't know about that, but I'd get polarized lenses. Reflective lenses tend to be polarized as well, but the polarization gets rid of light scatter that is reflected off surfaces, which comes as horizontal waves of light. And horizontal light waves are what create the glare that we see. So having polarized lenses can do that without having any change in the tint. So you can still let light in without getting the glare. And again, otherwise, as far as getting more light in, no tint is the most light you're going to get. So, yeah. Yes?
I'd like you to make comments, please, on the advanced treatment for acute dry eye. And I'm referring to the surface of the eyeball.
Surface of the eye, yeah.
Yes, what's happening in that?
Yeah. So dry eye is a massive problem. And I was looking at the number of drugs that are made for dry eye. And the list is like this long. That tells you it's a huge problem. If you just think of even what's over the counter, there are, I think, something like 16 or 20 different kinds of artificial tears that you can get. So at the first step, I think if you have a really difficult problem with dry eye, there are two things. One is, why do you have it? And sometimes it's related to systemic diseases. So people who have autoimmune conditions, or people who have a condition called rosacea, those kinds of, they're systemic diseases, but they can affect the tear production, not the quantity, but what's in the tears or what isn't in the tears. And so sometimes it will change the pH of the tears, it'll change the chemical makeup of the tears. So getting a diagnosis, if the dry eyes is related to a systemic problem, is step number one. After that, the next step is to evaluate what's making the tears. And we get, our tear film comes from three parts of our eye. There's the big tear gland that sits up in your orbit on top of your eye. That makes the water part of your tears. There are glands in your eyelids that run vertically, both in your upper and lower lids, and they have little tiny openings right at the margin of your lid where your lashes are. And those secrete lipid materials. And then in the white part of the tissue that covers the white part of your eye and the lining of your eyelids, the conjunctiva has a kind of cell in it called a goblet cell. And those goblet cells make mucins. So when we look at the tear film, it's a sandwich with most of it being the watery component, the aqueous component, and that comes from your lacrimal gland. That's what's affected frequently by systemic diseases. On top of it is a lipid layer that comes from those glands in your eyelids, and the mucin layer is the bottom layer. And those all three have to be there in the right proportions to have a stable tear film. So dry eye is frequently not so much a lack of tears, although it can be, but an abnormality to the tears where they don't do what they're supposed to do. They break up and they don't coat the surface of the eye properly. They don't nourish the surface of the eye properly. The aqueous part has nutrients for the cornea, and there's all kinds of antibodies and immune things to fight infections and things like that. So the tear film is actually a lot more complicated than what you might think. So step number two is to analyze the tear film and find out where the deficiency is. Is it lipids? Is it mucins? Is it aqueous component? And so that becomes a little more complicated. And there are now people who are dry eye specialists and have dry eye clinics, and they've got machines and diagnostic equipment that can look at the lipid glands and see whether they're functioning properly or not, and can recommend treatments that can help that particular problem. There are all kinds of ways of looking at the aqueous portion of your tear film and deciding, do you make enough? And is it, typically it's a quantity issue more than anything. That's an easy test to do. And then you decide, based on that, what kind of eye drop to start using. And then after that, sometimes it's a combination, depending on multiple deficiencies. And then it gets down to the frequency of how often do you have to put them in. And so, again, it's a lot more complicated. It's a frustrating condition. Very frustrating. And if you are one of those frustrated people, if you haven't, I would go to a specialty dry eye clinic and have them see what they can do to analyze what's going on with the tears and tear production and the makeup. The one area that's a real frustration for us is we do not know how to replace the mucin layer. And that sort of mixes everything and it keeps the tear film stable. So that's the one deficiency that we have trouble with. And sometimes without the mucins, with mucins, but without the aqueous component, we get fats and mucins mixing together, making sticky, filmy strings and things like that can erode the surface of your eye, and that's painful, and those cells have to regenerate. So there are mucolytics that will dissolve the mucins. And so the mucolytics and the lipid treatments aren't done as commonly. Everybody gets aqueous replacements. That's by far and away the most common thing that everybody gets. And sometimes that's just not enough. It doesn't work enough. You need the lipid replacement as well. Some people have discovered if they have a lipid problem, if that's been recognized, that their glands that make these lipids are plugged up. And if you heat your eyelids with warm compresses, they even make masks that will heat. And they even make fancier masks that not only heat, but massage your eyelids to sort of encourage the lipids to get out of their glands and through those openings and onto the surface of your eye. You can do that. If you have an aqueous deficiency, in the wintertime, it's hard because houses get warm and they have no humidity. And so humidifiers can sometimes make a difference just from an environmental standpoint. Yes, the question was, are there dry eye clinics in Columbus? Yes, there are. I know that for a fact because Ohio State has one, and it's at the Post Road building here in Dublin. A doc named Dave Castellano operates that. I'm sure there are dry eye people around Columbus in general that can do the diagnostic work that's required. But in the old days when we trained residents about dry eye, I was like, yeah, artificial tears. And now we've learned it's a lot more complicated than that. So what else?
One last question.
You say something about, PXE. I'm very sensitive to light, and the diagnosis was that I have a PXE problem.
Okay, so
Asking about PSD with a sensitivity to light.
PXE, right?
Yeah.
PXE.
The muscles don't work appropriately, opening and closing.
Okay. The acronym PXE is generally used for a retinal condition, pseudoxanthoma elasticum.
It's not, I believe so, but it's not retinal. It's the muscles that open and close.
Okay, there's ptosis. There's dermatochalasis. Those are eyelid issues, or is that what?
No.
No?
No, it's the muscle that opens and closes the opening in your eye.
Oh, the pupil.
Yeah.
Okay, so, pseudoexfoliation? Is that what you're talking about? Pseudoexfoliation? Yeah, okay. And what's the question about it?
Well, just do you know anything, can you give me any insights? My ophthalmologist is saying when the cataract, which I have a cataract on this.
Yeah.
When that's removed, she's going to do some surgery on that, so.
Okay.
It'll work better.
So the question is related to a condition called pseudoexfoliation syndrome. And that's a condition that affects the iris of the eye. And as your iris opens and closes, it rubs off the pigment from the back of the iris. And so people can end up getting what we call pseudopupils or things like that let extra light into the eye. And that can create double images or glare and halos and things like that optically. The other thing, two other things that it does is when those cells are shed from the back of the iris, they can gum up the meshwork that lets the fluid flow out of the eye. So pseudoexfoliation and glaucoma can sometimes go hand in hand together. And so then that's another issue. And when the cataract surgeon is going to do the cataract surgery, because the iris has lost a lot of its structural integrity, it can move around and flop around and be a real problem during the phase of surgery where there's fluid flowing in and out of the eye and there's a lot of dynamic stuff happening. And so sometimes the surgeon may have to repair a hole in the iris, or sometimes if there's already a hole there, they can stitch it closed. So I don't know if that's what's being planned for you, but that's what part of the, yeah.
Just a little aside, it seems like the eye is so small, but horribly complex.
The eye is about an inch in diameter. I gave a talk yesterday that I threw out a fact that was kind of interesting when I was talking about retinal cells. And I won't get the numbers right, but I compared our retina to a 4K television screen. And the 4K television screen has about 8.3 million pixels in it. The number of photoreceptors and the way they work in the retina is the equivalent of about 576 million pixels. The rate of information transfer that at any one frame of time, the retina is processing about 3.8 gigabytes of information. And the way we see is that we have cells that start and stop the impulse at a cycle of 55 cycles per second. So in 1 second, if you multiply that 3.8 times 55, whatever, in 1 second, the retina processes, I forget how many, it's like 380 some gigabytes of information in 1 second. And that's just being processed in the retina. And so the retina, the input goes to your brain, to multiple places. So when you see something, it might trigger a movement of the eye. You can do that voluntarily or involuntarily. It accounts for the ability to track smoothly when you're following something that's moving. It accounts for edges, for contrast, for color. When you see something and it makes an emotional impression on you, there are parts of our visual system that connect to that part of your brain. There's part of the visual system that connects to language. So when you read a word, you see that, it registers an image or an emotion or something. It's amazingly complicated. To me, it's fascinating, but it's just amazingly complicated.
Thank you. Well, I think we'll go ahead. Go ahead. We'll wind it up now, but I do want to thank Pat Corbido for suggesting that we contact Mackenzie, who's part of the Assistant Development Director at OSU Wexner Center. And we especially want to thank Dr. Lesser for a very, very informative talk. Thank you so much.
Thank you. It's been fun. Thank you.
Please stop by the table.
No.
There's some things you might be interested in.